TARE means trans-arterial radioembolization is another vascular-based interventional procedure. Technically, it's quite similar to TACE, to the trans-arterial chemoembolization techniques that we are applying now more than 30 years. TARE is in the field there since the late 90s of the last century, early 2000s. We started basically as one of the first centers in Europe in 2001 with the first patients. So the idea is to translate what we learn, what we know from radiotherapy, the oldest oncological therapy. The first radiation therapy was done in 1895, so it means in the same year when Röntgen found the X-rays. So translate these effects that we know from radiotherapy that has techniques like brachytherapy, where you put in the radiation source into the target. So what we are doing with TARE is we have micro radiation sources, microspheres loaded with Y90, yttrium-19. It's an artificially produced beta radiation particle. And we can deliver these micro sources into the tumor using the pathway of the tumor vascularization. So that's the underlying principle of radioembolization. So what we need to plan that is the same like in other treatments. You have to stage the patient. The issue is that radioembolization TARE is a liver, at the moment, a liver-only therapy. So selecting the patient means the hepatic disease, primary or secondary malignant disease, has to be focused to the liver. If you have significant extrahepatic spread, let's say lung metastases that is ruling the disease, or brain metastases, it does not really make sense to focus on the liver alone, because then you go for a systemic therapy. Additionally, the liver function must be sufficient. There are some kind of exclusion criteria saying if you have a severe metabolic deterioration of the liver, then the same exclusion or contraindications apply to radioembolization, because then you might harm the patient by further deteriorating the liver function. The indications are primary tumors like HCC or intrahepatic cholangiocarcinoma, as well as secondary ones like typically metastases from colorectal, breast, lung cancer. These are the typical indications. And the indication should be set up together with an oncologist, because usually the patients are treated and in the hand of the oncologists, so that the concept of therapies are put together ideally in an interdisciplinary tumor board, where all specialists come together, decide on the specific underlying disease, the options of the patients, and then choose the right treatment.